Well, thanks again for inviting me back for this part too. So we're going to tag team this actually slide by slide. So again, this is really imperatives. If you're running a IBD center and leader within the current reimbursement situation with a political situation, which is a very big part of our medical care, what do we do? Disclosures for Tom.
So, I thought it was important as we had modified the framework by which Advances is going on and sort of recognize that a number of these talks are not quite the very dry science talks that many of us have gotten used to and have sort of approached something of a TED Talk. I thought it was important to point out that this will not exactly be the kind of TED Talk that you're used to. So as David very elegantly, I thought, in one of the early slides on the last presentation, went through the nature of the relationship that really starts, or we tend to think of it as starting with the doctor and the patient, but in reality there's so much more surrounding the patient than just the caregiver and the caregiver's team. There are a number of purchasers involved, there are a number of payers and their intermediaries involved, as well as a number of producers of different kinds of services. The initial title of the talk that John and I were tasked with giving was "What Should Medical Centers and Administrators Do in Order to Optimize Patient Care in Our Complex Environment?" Certainly a mouthful, at least for me. And I think it's important to point out that administrators and healthcare systems are really involved in wrapping themselves around the entirety of this relationship and hoping that that patient gets kept at the center in very much the way that Corey Siegel and Steve Hanauer pointed out earlier this morning. It's not just about keeping our patients happy, it's really about providing all of the care that they need. And this is what medical centers do or can do very well, and we really provide, I think, the best opportunity to do this and get rid of a great amount of the waste that exists in our healthcare system that's making it so expensive and rather unsustainable. So medical centers and their administrators, raise your hand if you know who these guys are and what movie this comes from as well. So for all of you guys under 40, this is not Brad Pitt and his uncle. This is Robert Redford and Paul Newman in Butch Cassidy and the Sundance Kid, and as they're chased throughout South America, they constantly keep turning around and saying, who are these guys, right? So who are these administrators in these healthcare systems who are doing all of these things to us? Why is it that they care about patient experience? Is it just a marketing gig, or are they really committed to an improved patient experience? And so really, what they do is they serve the mission of the larger institution, and they're the intermediaries between all of us, and I am both an administrator and a practicing physician, between all of us and the larger world. So they serve really at the behest of the CEO and the Board of Trustees. All administrators do. They do serve that mission. They know the mission statement well. It should be in many of their slide presentations. You'll see ours in a minute here. They also really seek adherence to the larger vision, where the institution is heading to. They also adhere to the core values, and they really want to be sure that everyone who works in the institution, from the person who buys medical equipment to the person who might clean the bathrooms, to you, the caregiver, are committed to that vision and committed to the core values and the pillars that set it up and to serving that mission. And they're really overall responsible that that mission can be sustained. And so they really care deeply, as you all know from your RVUs and your ledgers. They care deeply about the financial health and success of the institution so that they might be able to continue to serve that mission. And I got to put my glasses on. I thought 20 Point a couple years ago was good. I'm like, yeah, it's all right. I got them in here somewhere. Or maybe I lost them. It's all right. The mission of Mount Sinai, the mission of the Mount Sinai Health System is to provide compassionate, patient-centered care with seamless coordination. And that's the key of it. It's seamless coordination, it is patient-centered care, and to do it and serve all the communities that we work in. That's what we're up to. I really do need my glasses here, John, unless you can read for me.
The vision is to continue to grow and challenge convention through our pioneering spirit, scientific advancement, forward-thinking leadership, which is Tom, and collaborative approach to providing exceptional patient care in the many unique communities we serve.
And this one I've got committed to memory, so I don't need you here, John. But the pillar values are always there, and many of you have similar values at your institutions as well. We seek to be passionate about what we do, right? We're in healthcare for a reason, and everyone recognizes that. We need to be empathic. We really have to care about our patients. We need to be creative in our solutions, hiring pharmacists, sending out early morning tweets, whatever it is to do it. We need to be agile, and we need to be collaborative. Those things are all essential to what it is that we do. So a number of years ago, Don Barrick, then at IHI, before he came to run the Center of Medicare and Medicaid Services, or CMS, came up with this concept of the triple aim. And the triple aim was really a great advance because I think it bound together every hospital administrator, every healthcare system administrator, probably every healthcare giver or provider who never even knew that Don Barrick existed or what the triple aim was. But it does explain what we do in the larger context that John did such a good job of putting together when it came to legislation in his talk earlier. So we need to improve care for individuals, we need to improve the health of populations, and we need to reduce the per capita costs. And those are all difficult challenges. And actually, if you talk to Uwe Reinhardt, who John referenced earlier, one of the great health economists in the US at this time, we try to do all these things, but we always fail at one, and it's a very difficult challenge. And improving the care for individuals, which is sort of the more retail business of care delivery that we see in the office when a patient is in front of us or over the phone, even if that phone is tucked between our shoulder and our ear, as Corey Siegel pointed out this morning. It's a real, it's a very important and fundamental thing. And so when we want to think about it, he came up with these things that you've seen before that he borrowed as well from the Institute of Medicine, which is that the care we deliver has to be safe. And it is all about safety and quality at our institution, or at least that's the goal. Zero harm, right? Any medical error is one too many. It has to be effective care. It has to have patient-centeredness to it. It has to be given in a timely fashion. It ought to be efficient, and it ought to really affect everyone. And that's what the equity means here, as opposed to the equity markets that we hear about so often. So now I turn it over to John and look for my glasses.
So many of us work in an academic institution, and here's the academic's dilemma. We have a tripartite mission of research, education, and clinical care. And as everybody in this room knows, the clinical care now has crossed the line of research funding in terms of academic health systems majority revenue. But we also have a tripartite margin, and that has traditionally been based on a commercial payer subsidy, which is really becoming less and less. It's based on the last decade where most academic health systems have gone through mergers and acquisitions. Michigan, I think, was the last academic health system that only had a single campus hospital. We've now expanded. And we've also based a lot of our sort of make-up money on philanthropy. And of course, we're highly dependent on NIH indirects. And I would say under that tripartite margin column, all of those are under intense scrutiny, if not full frontal assault, for a lot of reasons. And a lot of it is because we are actually too expensive. So as you start thinking about your strategy, this is our basic challenge. Academic health systems can no longer just be a little bit better, but remain massively inefficient. And I've now worked 27 years in private practice, and now the last decade, and before that, the previous decade, in an academic health system. And really, I'm into the administration and finances of those systems, so I really understand some of the massive inefficiencies we deal with. But also the opportunity is that 5% of patients use 50% of healthcare resources, and those are patients that we're pretty good at taking care of. And so that represents a real opportunity for us in terms of financial return. So from a patient standpoint, here's what the healthcare system looks like. So if I had to boil things down into one slide about what we all should do as administrators and physicians, it's figuring out how this woman can navigate her way through healthcare systems. The reason it's a woman in there is because 80% of healthcare decisions are made by women for themselves, for their families, things like that. And so they're the ones that, for the most part, are fighting the complexity of the healthcare system. So our job should be to make that simpler. We can't keep going like this. The line on the top, of course, is United States spending. We now spend half of the world's healthcare dollars, fully half, and our costs are skyrocketing, and they're just now mitigating a little bit for multiple reasons, but we're way ahead of any other industrialized country, and yet our outcomes are not proportionally higher. So in the MACRA legislation, which was 2014, basically mandated that Medicare lead the way and change the way we're going to be paid. And so, as you all know, there are two systems. One is called MIPS, or Merit Incentive Payment System, and the other is Alternative Payment Models. And so most practices now are on the right-hand side. Sorry, I'm dyslexic, but on the right-hand side under MIPS. And so that has to be paid attention to. And your scores in 2017 are going to reflect your reimbursement in 2019, so there's going to be a 2-year lag. So it's very important to pay attention to that. Here are some of the alternative payment models, and they're in 2 different formats. And so you have to think about this as you're beginning to reconstruct your practices. The first are alternative payment models that are focused on an individual patient. So this is bundled payment, reference pricing, both of which we have examples of now. And the second are population-based, and this is the medical home, the total cost of care, specialty medical home as well. So you have to figure out within the patients that you serve where they might fit. Typically, only about 1/3 of a health system's patients get their full care within that health system, and so those would be applicable for population health. The rest of it would be the bundled payment and reference payments, which is more individual. This is the theoretical time shift from fee-for-service to value-based. So many of our health systems have been ready to flip to value-based healthcare for many, many years. And once we cross that line, which represents probably about 40% of patients here into value-based, that's really going to change our practice. Well, a typical health system will have 5 to 6% currently of their revenue based on true value-based medicine. The rest is on incentive funds, things like that. So we're still really waiting for this flip. And it's a very, very hard time to be in that kind of hybrid mode. So what do I think are the survival imperatives? If you're thinking about your practice or you're thinking about your health system, you have to reduce the administrative burden on physicians. And so that there's going to be, hopefully, a revolution in EMR technology that's going to make those transactional costs less. We have to increase efficiency, reduce the cost of care and access. That means building team-based care, as you've seen, reducing transactional costs. So if you do what's called a value stream map from the time the patient starts in your practice until the end of that episode or whatever it is, and map each step of the way, your role as administrator is to reduce the transactional cost of that process. And then really align incentives and compensation. Minimize inefficiencies, really understand retail health. Whether a patient's insured or not, you can be sure that they have a high deductible in most cases. And so that means that for a large part of their care, they're going to be paying retail. And also begin to think about managing to Medicaid. And this is really focused on the psychosocial and environmental supports that are necessary for our patients, and particularly patients with chronic diseases like IBD patients. Operational imperatives. You have to monitor operations and provide feedback via dashboards, and Tom and I have discussed this at length. We're both in positions of having to provide those dashboards and feedback to our physicians. After-hours access is probably the biggest determinant of patient emergency department use. Risk strategy, risk stratifying patients. Access, urgent, emergent, routine should fall within the chronic disease model. Proactive outreach to patients, particularly the high-risk patients who are at risk for readmission or emergency room use. Telemedicine is definitely coming. And again, we should not allow our faculty to fall into the RVU trap. I think that's a terrible way to pay faculty. It's what we have right now. But if you're talking about chronic diseases like IBD, that's really not a very efficient way. So we need to come up with better ways. Bridge clinics, facilitated access, and triage to the right place, the right person, and the right time.
Right. So, and I found my glasses. You know, there's so much that's important in what John said, and this concept of dashboards and knowing everything that's going on in the population of patients that you particularly take care of is really essential. And we have to always measure, right? You know, Lord Kelvin of the temperature measurement said, if you can't measure it, you cannot improve it, right? So how well you are doing can come down to what is present in your dashboard. And you should be working with your colleagues, with your chiefs, with your administrators, chairs, chief medical officers. You should be working with everybody to try and find out or to improve on that dashboard that you have. And that dashboard should mostly be focused on safety and safety measures, outcomes where you can get them and that are really important or relevant, and I didn't put that in there. And then obviously things like costs. What are your readmission rates and your ER visit rates, right? These are the easy ways that in a value-based system that we are moving toward, and we're not there yet, as John pointed out, and he's 100% accurate. Mount Sinai is stuck at 6% value-based contracts. Readmissions and ER visits are a really, really easy place for us to figure it out and really make substantial improvements. And then finally, medication use. We're going to see some big changes in the next few years. A lot of what has helped to drive hospital-based financial success in a not-for-profit world has been the 340B program, which really supplements payments for a number of different medications so that we can help to serve the underserved amidst us. But that's going to have pressure put on it, as was just announced by CMS 2 weeks ago. And then another thing is experience, right? Patient experience is hugely important. And around these dashboards, we need transparencies. Jean-Fred can tell you, or Bruce or any of us from Mount Sinai, that each and every quarter my office puts out a performance where everybody has their patient experience numbers made available to everyone else in their department or their division. You know, some people pay attention, some people don't, but at least we're going to get moving. We will eventually get comments live out there. They're already out there on healthgradesandvitals.com. It seems to me that the institutions should be doing that as well. We want to support the activities of all frontline caregivers, so they should be funded not just for their clinical activity, but for their administrative, research, teaching, and those areas where there is strategic importance. We need to support integrated care networks and teams. We heard a lot about that this morning. That's very important, and I think administrators get that. We need to embrace disease complexity, and we need the alignment of the mission, vision, and values with the clinical realities that are out there. We need to align and create the proper incentives and to really figure out how to better drive outcomes with that accountability and transparency leading the way. And I left you a little bit of time, John.
So conclusions, highest priorities, understand the future. We will have diminished resources and a demand for integrated care. And again, I think the disruption in medicine is probably going to come from outside of medicine, and it's going to be very fast. Look at the facility physician schedules, comp model, productivity thresholds, and align the incentives. And that often has to be done at a health system level, not even at a division or department level. Search for efficiencies and delegation of responsibilities. One of the most frustrating things I can think of is the misuse of RNs, for example, using them as scribes and transcribers, as opposed to using them at the top of their professional license. Dashboards, we've both mentioned, that's what drives behavior, and then manage to Medicaid. And I'm not talking necessarily about the Medicaid population, but people with the kind of psychosocial and environmental problems and barriers. We have to learn how to manage that. And then finally, balance the tripartite mission of academic medical centers and practicing physicians as well. And thank you very much. I think we're right on time, Steve.